Excellent. Welcome, everybody. I'm Sharisa Fatinos. I am the Medicaid and Behavioral Health Medical Director at the Healthcare Authority. I want to start with an apology. This was and is an open public meeting. We had changed our agency policy recently, and the next meeting that we have, there will be the opportunity for in-person attendance in Olympia if people would choose to, would like to participate in person. We will have that available at the next meeting that we have. We don't have scheduled yet, but again, apologies. Did not appreciate the need to set up an in-person meeting today, but as mentioned, it will be recorded. So welcome, everybody. I see a number of familiar names as well as some new ones. We'll take a couple minutes here shortly to go through the committee members on the phone. Can we get the next slide and actually the next one? So we welcome folks. This is sort of the version 2 of the Psilocybin Task Force meeting series, as it were. A number of us met for the last year and a half, and after the last legislative session, we've been given some new work and a new deadline. We'll review that. Mike and Haley will go over that in just a couple minutes in more detail. Wanted to start by saying a couple things, just reminders to folks who are either new to this committee or new on the call. We have at the Healthcare Authority a very subscribed piece of work that we are responsible for with this next part of the legislation. And again, Haley will go over that for us. The focus is, again, largely clinical. And I recognize that a lot of the work that we did over the last year and a half was really with the group's direction focusing on a wellness model. I think that as an agency, we have to respond to what we are legislated to do in the law. So we will develop and provide the report so it meets the letter of the law. And as I mentioned last time, we really want to use this opportunity with all of you and your expertise to get as much information as we can to offer what a both clinical and wellness model, should they go forward in the state, the considerations that need to be there and the things that we need to think of. So want to just say that our obligation legally through the law is to look at the clinical perspective, but we also recognize that there's huge interest in this. There are other states that have gone forward with this, and we want to make sure we're able to identify considerations for whatever groups might take this on in the future, whatever the legislation may direct. So just wanted to point that out. Also want to start by sort of recognizing and give an appreciation to Rick Escobedo, Drs. Price and Silvas. Dr. Silvas is not able to join us today. She's in a part of Oregon without access, but they have asked that we reconsider the equity survey with their help and DEI lenses in developing it. Duncan will be helping to support that work, and we will be redirecting that out using some of their and other contacts that groups have, so we can make it a little bit more useful in trying to reach the communities that we initially were hoping to and were not as successful. I see a question from Lisa. The clinical perspective means for use of psilocybin in healthcare settings. And so the definition that we assume that means is in a again, in a healthcare setting, whether that be facilitated by a master's level clinician, a physician's assistant, a psychiatric ARNP, other ARNP or physician, but that really the intention of this particular legislation is to focus on the use of psilocybin for the treatment of a clinical condition, as opposed to a wellness model where people are seeking enlightenment, fulfillment, other words that I'm not going to get right. So that's sort of the distinction there, Dr. Price. Again, want to be able to hold both conversations as we move forward, but recognizing that for the formal report, it will be really as we've been directed by by the legislature. So I want to stop there for a couple minutes and just go around the room and ask if people would introduce themselves. And this is for committee members, if folks would introduce themselves. And Dorothy Ann, can you go ahead and go down the list? I am having a hard time. I don't have the list of folks in front of me to know, or the initials. If you wouldn't mind doing that, that'd be great.
Yeah, absolutely. And some folks have just their first name on here. So we have I don't know.
Who is that?
Oh, I bet you that's Beth Church. I'm so sorry. And we have Senator Jesse Solomon as a guest today. And then let's see, Dr. Caitlin Ryan.
Oh, yes. Would you like to introduce yourself?
Yes. Hello. My name is Caitlin Ryan, and I'm the Executive Director for the Cannabis Alliance. Have lots to offer on the regulatory journey cannabis has gone through over the last 10 or so years, and would hopefully keep psilocybin out of some of the pitfalls that we ran into, as well as, quite a few of us in the cannabis space are also practitioners around psilocybin, and looking forward to a sensible regulation process here. Thank you.
Thank you. And then we have Gary Barr from Department of Ag.
Yes, hello, this is Gary Barr, Washington State Department of Agriculture. I'm the science liaison, the director's office. Glad to be a part of the task force. Thanks for the introduction today. I have a responsibility in the director's office related to water quality, pesticides, natural resources, any sort of environmental concern. I've also had a history of working in food safety, and I'm a FDA commissioned official within our department and our state related to various food safety categories. I'm just glad to be a part of the committee. Thanks for the opportunity.
Thanks, Gary. Next, we have Dr. John Roll from WSU.
Good afternoon, everyone. I'm John Roll. I'm the Vice Dean of Research for the Washington State University College of Medicine. I'm also the president of the Washington State Academy of Sciences. And potentially of relevance for this group, I'll mention I'm the chair of the NIDA Research Development Committee for the Clinical Trials Network and a co-PI of the Pacific Northwest node of that group.
Thank you, John. Next, we have Dr. Lisa Price from the Institute of Naturopathic Medicine.
Oh, sorry. I thought we were just doing board members. I'm a public participant for the last, I guess, 16 months. And just here to lend a hand with regards to clinical information and data on psilocybin and its indications and use. And of course, equity stuff too. Thanks.
Thank you. All right, and then next we have Dr. Nathan Sackett, also from UW.
Hello, I'm Nathan Sackett. I'm an addiction psychiatrist at the University of Washington School of Medicine, and there I'm an assistant professor. I'm also a co-director along with Dr. Darren Smith of the Center for Novel Therapeutics and Addiction Psychiatry. It's a center where we focus on the use of emerging compounds, including psychedelics, to treat substance use disorders. And happy to be here.
Thank you very much. And then next we have Seth Mayer, who's representing military veterans.
Hello, good afternoon, everybody. My name is Seth Mayer. I'm representing the veteran population here. I am a veteran with lived experience with post-traumatic stress, moral injuries, physical injuries. So, and there's a lot of therapeutic benefits with the use of psilocybin, not only for the mental health, but also for physical health. It's helpful for pain. So there's a lot of other benefits that can benefit the veteran population, reduce the use of opioids. Just thinking about the veteran that is also susceptible to a higher rate of suicide, and looking at this as a pathway to potentially offer some relief before they make that ultimate choice. Thank you for including me. It's an honor to serve.
Thank you, Seth. Right, and then I'm showing Rick Escobedo, and I apologize, I don't have you on my agenda, so I'm not too sure where, who you're representing, but if you wouldn't mind coming off mute and introducing yourself, that would be amazing, please.
Hello, everyone. I'm Rick Escobedo. I'm a licensed clinical social worker, and I'm out here in Piscosa ancestral lands in a little Bavarian themed town called Leavenworth, Washington. And I work in public service. I'm here to support with the survey, the public side, working with Dr. Lisa Price. My background is working currently with migrant agricultural families, communities, indigenous communities here in North Central Washington. And my clinical experience spans from British Columbia at University of British Columbia, Vancouver General Hospital, and Stanford Hospital and Clinics. Thank you all for your work you're doing.
Thanks, Rick. And then it looks like last but not least is going to be Brian Jansen, religious practitioner.
Hi there. I'm just trying to get on here.
You're on. We can see you.
Hi. Well, I missed the other introductions. I'm sorry to say. That was Rick from Leavenworth I just heard. Yeah, my background goes to the ayahuasca churches out of Brazil, and I've been attending some of these meetings and found them very interesting and useful, and appreciate what you guys are all doing here.
All right. Well, thank you. Are there any other committee members on the call that we have yet to identify through our scrolling here? If so, please introduce yourselves. I do see Lacey Fehrenbach from the Department of Health, and I know she's not able to, she is in transit, but I see that she is joining from the Department of Health. Senator Solomon, would you like to say hello to the group?
Sure, I'd love to. Can you hear me okay?
Yes.
Good. Thank you. I guess we have some new members and some continuing members. I always really appreciate the contributions that you have to make. And for those of you who have been on a while, and I appreciate that you're continuing to stay on. I think we made a lot of progress this year. I said this at the last meeting. Even though we didn't pass forward, we had a very strong bipartisan show of support for whatever we do moving forward. It's really not a clinical hybrid model, or it's going to be a wellness model. I don't think any of that's really been worked out. I am very eager to figure out where the support is. Obviously, I supported the Oregon model in my bill, so that's my inclination, but I'm always happy to take input. I just got back from the MATS conference, the psychedelic conference in Denver, which I thought was amazing, and it had a huge breadth of presentations and everywhere from Amazonian tribal leaders to vulture capitalists. I'm sorry, I didn't mean to say that. Venture capitalists trying to synthesize and for profit the natural medicines. So lots to talk about there, but I'm excited for continuing the work. I have some ideas for next session, but probably a little too early to share, that we can push the boundaries on this a bit, but I think successfully. Thank you all for serving here, and I hope to meet you soon.
Great, thank you, Senator. I want to turn it over to Haley to go over the history and scope of the current work, and that might be worth in between that and listening to Dr. King from to talk about the clinical research proposal, maybe sort of continuing to frame a little bit of sort of what the purpose of this meeting is, and then kind of how we're thinking about moving forward with this committee. So Haley, I'll turn it over to you if that's all right.
Yeah, thank you, Teresa. So I'm going to start with a brief history of the last year or so of work, and then pivot to the most recent legislation and the upcoming work. And then we'll be handing it off to Val and Duncan, who will talk about the upcoming work this work group will be doing. So next slide, please. So this lays out the three major pieces of legislation that is affecting the work of this group. We have two from the 2022 regular legislative session, and then one from the most recent session. We are going to, let's do the next slide, please. Yep, we are going to focus on the first two pieces when we're talking about the previous work that this group has done, which was Senate Bill 5660, which did not pass, but proposed a psilocybin program in Washington State, very similar to Oregon's psilocybin program. And then Senate Bill 5693, which was a budget proviso that included the original funding for the Washington psilocybin work group, which had a preliminary report due last year and a final report due this upcoming December. And that was the group that a lot of you were involved in the previous year or so. So we're going to start with those two pieces of legislation and the work around that, and then pivot to the upcoming work. Next slide, please. So for the 2022-2023 psilocybin work group, just a slight name difference than the one we're in right now. It focused a lot of the work was focused on that Senate Bill 5660, which again did not pass, but guided a lot of the work. It would have established a psilocybin program very similar to Oregon's program with an 18-month program development period. And so that's on the left, kind of highlights of that bill, which I think a lot of people are very familiar with. On the right, we've highlighted some differences in the Washington State proposed program versus Oregon. Namely, the social opportunity program was in Washington in the 5660. It was not a part of Oregon's program. Also, in Oregon, they limited the use to one strain of psilocybin. That was prohibited in the proposed program in Washington. The Washington legislation included micro-tier manufacturing endorsements with lower fees. Again, not in Oregon. And the final difference was that the Washington group would have been tasked with establishing rules for consumption outside of a service center. In Oregon, it is strictly prohibited to administer psilocybin outside of a service center. So those were the main differences in that first original proposed bill, which was in 2022 legislative session, Senate Bill 5660. This was the focus of our previous work. Next slide, please. And in that work group, the required members from the budget proviso were listed here. Again, a lot of people on the call were involved in that work group, and include some representatives from various state departments, some researchers and clinicians, some members of different advocacy agencies. So this was the previous work group member requirements. Next slide, please. And so that work group was tasked with 5 specific tasks that were to be completed in the 2 legislative reports. So it was very specific, although I feel like we did have conversations outside of these 5 key tasks. These were the ones that the work group was specifically required to report on. So we'll walk through these briefly and then talk about the conclusions that were made related to the key tasks. So the first one was to review Oregon Health Authority's proposed rules for their psilocybin program and identify any areas where a different approach may be desirable or necessary. The second was to review the systems and procedures that were already established for cannabis in the state and determine if that system is suitable for psilocybin. Next slide, please. And then the third task was to review that social opportunity program and recommend improvement or enhancements. The final 2 were involved the Department of Health. One was to assess the functional requirements of the original bill and identify any areas that would exceed the expertise or capacity of the Department of Health. And then finally, to discuss how to integrate licensed behavioral health professionals in the practice of psilocybin. So those were the 5 key tasks. The next slide, please, we'll go over the main conclusions. So like I said, those were the work from the work group was centered around those tasks, but we did have additional conversations, and some of that, the additional conversations stemmed from what we found about key task 1, which were additional areas that may expand the version of Oregon's program, including microdosing policy, exemptions for personal, religious, or indigenous use, access to more than one strain, more protections for equitable access, and then applying a cost analysis to ensure affordable sessions. So those are things that the last work group recommended in addition to Oregon's program. For key task 2 around the Liquor and Cannabis Board tracking system, I think that was basically a unanimous decision that that tracking system could not be applied to psilocybin for many reasons. That was the conclusion there. Next slide, please. For the social opportunity program, we found members were generally supportive of the program, but did identify some areas for expansion, including integrating the social opportunity program into license distribution, setting aside a certain amount of percentages of licenses, establishing a civil legal aid program or funding for mentorship, and then having the criteria for a distressed area, which was defined in the social opportunity, to be as inclusive as possible and be able to apply on a case-by-case basis. Next slide, please. And then the final 2 key tasks were around the Department of Health's involvement. For the first one, we heard from representatives from the department that if the department was giving sufficient resources and time, there were no areas that exceeded their expertise. Sufficient time would be 3 years, and significant resources would include staff and IT infrastructure. And then for key task 5, which is about integrating licensed behavioral health professionals, Department of Health staff identified that this would require additional language to be added to any psilocybin bill, because in the 5660 legislation, there was not any language that would direct them to integrate behavioral health professionals. So this was kind of a recommendation for a future program. Next slide, please. So now pivoting to the current work. So that was an overview of what was discussed in the last work group.
Haley,
Now,
could I
yes.
ask to
Yes.
interrupt for 1 second? I think someone inadvertently tried to annotate on the screen and was successful, but there's left some marks. So if you inadvertently were trying to hit the mute button but got to draw on the screen, if you could erase that, I think only the person who can do it can erase it. So if that's something vaguely familiar to anyone, if that'd be great if you could remove those lines. Thanks. It's easier to see.
Thanks, Teresa. I want to pause and ask if there's any questions, I guess, on the previous couple slides about what was done in the last work group. Nope, sounds good. Okay, moving on to the current work. Next slide, please. So this is the most recent legislative session that established the Psilocybin Task Force to provide a report on psilocybin services due to the legislature by December 1st, 2023. So that is what this task force is ultimately assigned to do, is that legislative report. Next slide, please. Similar to the last work group, there's a lot of overlapping required membership in this work group or this task force, just like last year's group. So that's why a lot of the same people are on this call, which is great. Next slide, please. And then here are the highlights for what we are tasked to do. Number 1 is to provide a final report by December 1st of this year. The assigned activities fall into 2 buckets. There's clinical information and then regulatory structures. So this kind of goes back to Dr. Price's question about what kind of clinical information this task force is assigned at looking at. The key areas include, well, overall overarching, it's around the clinical trials, and key areas with specific attention to the populations that were excluded, factors that are considered during medical intervention, consideration of participant diversity in clinical trials, and identifying gaps in clinical research. So that is in the legislation, and Val will talk more about that in the next couple slides after this. And then the second task is to review and discuss regulatory structures for clinical use of psilocybin in Washington and other jurisdictions, nationally and globally. And to do this, we're also asked to look at how various regulatory structures address the concerns around public health and safety. And Duncan will get into this, the approach for the regulatory structures, in a couple minutes. Next slide, please. Now I will turn it over to Val, who's going to talk about the approach to the clinical research part of that, what we're tasked with.
Haley, can I stop you for a second there? Sorry, just for a second. Thanks. Guys, just if I can insert myself. So Mike Bonetto with the Center for Evidence-Based Policy at OHSU. And as Haley went over that, I think we've worked with many of you over the last, as Teresa said, year and a half. And we've been brought on to kind of help expand the bench at HCA and just provide some additional capacity. So it's been a pleasure kind of working with everybody. We're going to continue this work, working with HCA over the next, many months. We've expanded the bench on our side. So you're going to hear just from a minute from Dr. Val King, who really specializes in evidence-based research, is kind of a national expert on that. So we've been, I think, lucky enough to have her kind of come in and start looking at the psilocybin research, which she's going to kind of give this high level overview based on the Oregon work. And before we do that, I just want to take a step back because I saw just in the chat, Lisa, I think you had to leave at 1:30. Maybe you've already gone, but there was just some questions on the overall scope and work of this task force. I just wanted to make sure what Haley just presented, is that clear? Any kind of questions, comments, concerns, as we are kind of getting everybody on the same page about what we're going to be doing over the upcoming months? And Haley, can you go back, Beth, can you go back a slide or two? That one right there, because this starts to lay it out in terms of what we're going to be kind of overlaying over the next, several months of developing a work plan and make sure we're all on the same page. Questions, comments here?
I do have a question, just for clarification. How is most of the work that's being done or extracted for the kind of the sub reports that will be fed into the larger reports, is it done at these meetings or is it done outside of these meetings?
So I can take that, Lisa. So the way that it has worked and the way that we envision it working this time is these meetings will be an opportunity for the committee members to share their expertise, recognizing that the legislative scope of what the healthcare authority is doing is what is on this page. That is what we are by law required to do. We were not resourced beyond additional support from OHSU to do this work. We have till December to put up to provide the report. The focus, as I mentioned, of this report is from a health system perspective, clinical, and that's what we'll be hearing from Dr. King, recognizing that all along our discussions have, focused also on this is not something new to science. This is a tradition and religion, and people have been using these medicines for millennia. And we know that not all of the evidence or information that is important will be in the scientific literature. We recognize that and we get that. And we have to present that part for our responsibility, but we also want to have room in these meetings for conversations about what are the important considerations that those structured literature reviews and structured tasks that we have been given are not asking and answering. So we've kind of approached it from that perspective, is that yes, these are the things we have to by law do, what we are required to do as an agency, what our contractors, Oregon Health Sciences University, are required to do on behalf of us. And we don't want to lose the opportunity to have the expertise and knowledge of the groups who are of the people participating go without recognition, and figure out how to elevate those as we move these discussions forward. So it's kind of a both and.
Okay, so in other words, it's these board meetings serve more as a conversation and less as an answering specific questions. Is that correct?
To date, that's mostly been their purpose, right? To sort of go through the required tasks, service conversations, have committee members, share their concerns, their ideas, recognizing that there's a lot more information here that you all will have to offer than we've been asked to provide. So trying to balance those two things.
Okay, and then a final question before I leave, which is just a consideration, and this is do we all feel like it's working? Do we feel like there's something that can be done to enrich the process? Again, it's just a question. It's just something to consider for this very, very important subject. Thank you.
Thank you. I think that's something that we've left some time at the end to discuss with the group. Just sort of, taking a pulse on the folks that are on the call to see. And yeah, certainly something we'll come back to. All right, Dr. King, sorry.
Teresa,
Mike, go
sorry, I
ahead.
saw John had his hand raised.
Oh, and we didn't introduce Paul either yet.
Well, do you want to introduce Paul first, Teresa? I don't want to.
Paul, do you want to introduce yourself? Just a brief introduction. I saw you join.
Yeah, hi folks. I'm sorry I'm late. I was getting off the ferry. My name is Paul Stamets. I've been involved in psilocybin mushrooms since I was about 16 years of age. Published my first book in 1978. Went to the Evergreen State College with a covered by DEA license, which myself and Dr. View got. Published 4 new species of psilocybin mushrooms due to science. Then recently received a DEA license after working more than 2 years with the Department of Health, which holds they have a gate between us and the DEA. The DEA defers to the state. We do have our licensure now for analytical psilocybin. I'm very, very deep into this subject, especially with neuroreceptors, neurogenesis, neuroregeneration, neuroplasticity. And we have some really interesting evidence of that. I published 2 papers in Nature on meta surveys, and a psychomotor benefit from microdosing with psilocybin is inarguably significant, not related to placebo or expectancy. A tap test increase went from 48 to 68 taps in 55 plus year olds with a p-value of 0.004. So we are now dedicating millions of dollars to disambiguate the entourage effect of the neuroreceptors and the other tryptamines that are present in psilocybin mushrooms that are not being studied by any clinical trial. And I just would end by saying 99.9999% of the people using psilocybin are using psilocybin mushrooms, and 98% of the studies are on psilocybin, the molecule. So we think the natural form has a lot of utility. And if those of you are familiar with the last paper that came out on psilocin versus antidepressants, psilocin docks with the TrkB receptor 1,000 times more than antidepressants. That's at a macro dose. So, do the math, you reduce it to a microdose, you can still have efficacy. I predict that psilocin microdosing will replace SSRIs and also build new neurons as we age. Oh, that's enough for me. Thank you, Teresa.
Okay, so I'll just be brief. Mike, you had a slide up a moment ago. Could you, that one.
Sure.
So from my introduction, you'll all recall that I'm very comfortable in the clinical trial, clinical research space. That's where I live. But when I look at this slide, you have clinical information highlighted. And then below those bullets, you have clinical trials, clinical research. What I thought it meant until Teresa just gave a really probably pretty good answer is that the clinical information would be items that aren't contained in those traditional medical scientific approaches to understanding this, the indigenous experiences as an example. And not to say that's not described in the scientific literature, but as an example. So I guess my question is, are we looking at this, pretty easy to do review of the research writ large, or are we looking at other types of data as indicated by clinical information there, or are we augmenting both with each other?
Thanks, John. I think it's a fair question. I would welcome as Val thinks about this, and Teresa, I think we've been looking at this, guys, correct me if I'm wrong, but very much from that research lens. But anything else, I think it's a fair question to ask, and something we probably need to think through. But I think what you're going to hear from Val is very much focused on that research lens. I think that's where we're coming from. But I think that's I think a fair discussion.
Agreed. And I think I tried to touch on that a little bit, is that this is going, what our understanding of what we're tasked with is fairly limited. I mean, it's not limited, it's a lot of work, but we recognize and what are the gaps? What are the things that aren't being elevated in the typical research? So those are, I think we're doing both. And this initial, meeting is really focused on outlining the sort of review framework, the clinical review framework. We'll hear similar to what Oregon did, but we want to continue to mention and elevate those other pieces that John was referencing, because we would like to be able to have those presented as well. So Dr. King.
Great. Thank you so very much, Teresa. And let's go ahead. This is really to make sure that everyone is on the same level around where we're starting with the research and then how we would plan to proceed with it, given the framework of what your legislative action has asked you to do. So let's go to the next slide. We wanted to start out with summarizing Oregon's review work that many of you are aware of. Next slide. That report, which was published 2 years ago, asked some key questions around psilocybin based on the needs of Oregon's legislative action as well. So they asked about what the risks and benefits were for both controlled and unsupervised use for a list of specific conditions, including things like depression and PTSD. It asked about whether or not those risks and benefits had substantial variation by either the person, their health conditions, other characteristics, or particular things to do with the clinical environment. And third, they asked about whether or not there were risk assessment tools that would help to stratify patients for treatment, and whether there was anything that could guide around licensing or training of providers. And then finally, they asked about risks and benefits of different sources of psilocybin. So those were the areas that that particular report, issued a little more than 2 years ago, came to. It really worked to summarize both randomized controlled trials, which we think of as being sort of the pinnacle of clinical research, but as has just been pointed out, they're not the only type of clinical research. And that review also included systematic reviews or compilations and collections of those types of studies put together. Next slide. What was found in the Oregon review was primarily phase 1 and phase 2 clinical trials. Again, primarily about supervised use. And there were a few observational studies identified around unsupervised use. So we'd just like to summarize the high-level findings so you know what the starting point here is. There was evidence to suggest that psilocybin might reduce depression, anxiety, certain types of substance use disorder, including tobacco and alcohol. And those were in situations where it was used under clinical supervision with counseling happening at the same time. There was evidence that it might reduce depression and anxiety as part of palliative care. There was a little bit of evidence on short-term risks, which were primarily minor physical symptoms like vomiting and headache. And it's not to say that those aren't miserable when they're occurring to you, but that they were fairly short-lived. And there were also thought to be some temporary cognitive effects, both affect and cognition, so paranoia or grief. And then there was not evidence to suggest that there was substantial long-term negative effect, such as the worsening of depression or other conditions. Next slide. Oregon's rapid review didn't identify any validated risk assessment tools that might help to segment who might benefit or who would be at risk for use. Although they did identify commonly used screening practices that were really designed in the trials to weed out people who might have a higher risk of adverse events, but again, no validated assessment tools. Next slide. Around the sources of psilocybin question, so this was primarily a review that identified clinical trials that used biosynthesized psilocybin, say that fast 5 times. And the uncontrolled or observational studies really tended to more often report mushroom consumption as the source. And then concentrations of both psilocybin and psilocin did vary by dried mushroom weight in the summarized studies, but there are methods for establishing the analytic concentration and whether or not there is any contamination of those types of commercial products. So that is in the evidence as well. Next slide. This is in some ways a fairly limited set of studies in some ways. So the controlled studies did tend to exclude participants who had multiple comorbid medical or psychiatric conditions, which can obviously limit the generalizability beyond those populations. That was not necessarily true in the palliative care literature, because obviously those populations do have other comorbid conditions. There is a lack of diversity across the study populations that you see in these published studies. Participants are typically white, college educated, and cisgender, and predominantly male. Next slide. So Oregon had a whole list of next steps from this rapid review. You know, much of it, I think, echoes some of the questions that we've heard today already, and some of the work of this Commission 1.0 instead of this one, the preceding work. So they really felt the need to gather information and perspectives that weren't in the published literature, to both consider the risk of bias in the studies in making their decision, including the very preliminary or early stage of much of the research. They wanted to be able to continue this work on and make it a living systematic or rapid review. They felt the need for thinking about licensing and what the literature and other types of information might say about continuing education after licensure, and what the informed consent process might need to involve for consumers and full disclosure. They felt that there was some support for dosing parameters to maximize benefit and minimize both the risk of adverse events and dependence. They asked to consider screening processes, even though they had not found validated risk assessment tools, whether there was voluntary monitoring, service and consumption, and the knowledge base, and how to get that information back when use was increased in the legalized program. Trying to essentially use research beyond randomized trials to develop the regulatory framework. So you'll see some of that in Oregon. They did prioritize certain types of cultivation based on grain-based substrates instead of either wood or dung because of toxicity concerns, and then wanted to know about the feasibility of DNA sequencing of fungal tissue for quality control or licensing of particular products, and then developing a safety assessment program or screening requirements to try to eliminate dangerous contaminants. So that's where Oregon got to after the 2001 rapid review. Next slide. So let me talk just a bit about what we have planned to do for updating that rapid review for your use. Next slide. So we think that the key questions are largely still applicable. So risks and benefits for improving condition symptomatology and also general quality of life around a range of conditions, including depression, anxiety, obsessive compulsive disorder, trauma-related disorders, including PTSD and racial trauma, substance use disorders, palliative care, spirituality, or other concerns. So really taking almost any condition. Thinking about the risks and benefits of unsupervised use, seeing if there's anything new around either provider or patient risk assessment, and then thinking about whether there are any updates around potential risks of different sources of the agent. Next slide. We also plan to continue on searching for RCTs and systematic reviews. In order to do that, we have expanded a little bit on what they did for the Oregon review. So not only using Ovid Medline and PsycInfo and the Cochrane Library, which are 3 established databases, but we have found that there are some journals, including the 4 that you see here on the slide, that are really poorly represented in those databases. And so we have conducted a hand search of those from the beginning of 21 until May of 23, so May of this year. Next slide. We're doing pretty standard evidence review stuff. I won't belabor it, but it includes dual review at both the title and abstract and full text stage, dual quality or methodologic quality assessment and abstraction, and then summarizing that all in an updated rapid review for you. Next slide. I'll just let you know where we've gotten to since we've started this work. In the defined databases of Ovid Medline, PsycInfo, and the Cochrane Library, we identified 246 new publications. In the hand search of those 4 journals, we identified 39 new publications that were unduplicated with those in the databases. And we are currently working our way through those abstracts and titles, and we've moved on to full text review. And I think at last count, we had about 68 studies move into full text review stage. It's actually sort of difficult in this work to tell you how many might move on to the full report. Next slide. We tend to use a methodologic quality to give you an assessment of this research and its risk of bias. And we are lumpers, not splitters. So we'll talk about the limitations of the research, but bucket it into good, fair, or poor methodologic quality based on whether we think the methods and the reporting of the methods control for most of the biases, or whether the study is really subject to such flaws that it might not be reliable and has quite serious bias. Next slide. Okay, I think that was the end of that rapid review section. But before I turn this over to Duncan, let me just ask whether there are particular questions.
Belle, did you see the question from Paul in the chat about Porta Sophia as a database?
No, I do not, Paul. So if you want to send that on to us, we can take an examination of it.
Okay, happy to do so.
I can pop my email into the chat for you.
Okay, excellent. Thank you for that overview. Very, very important. Let me know how I can contribute. I will mention we just had our second FDA inspection in our facility. We're CGMP compliant. And we also, we've generated $60 million in Mycomedica to do clinical research, which we'd love to keep in the state of Washington, but frankly, it's too difficult. So it's unfortunate, but if I can help navigate the clinical trials in the state of Washington, I certainly have a lot of information, as does my team, because this is taking way too long. But we can pick that up offline. Thank you.
Mike, Val, thank you very much. Mike, do you think this would be an opportunity to have Nathan share his work under the legislation? Or did you want to come back to that?
No, Teresa, I think that would be great, just to kind of, Nathan, if that's all right with you, just so it kind of connects to this and get, so everybody kind of knows your scope as you lean into this as well, that's connected to this legislation.
Yeah, sure. Hi, everyone. So again, my name is Nathan Sackett, and I am working with folks at the University of Washington to implement a pilot project that was part of this legislation. So essentially, the short story is that in the prior version of the bill, there was concerns of safety, and one of the main gaps in the literature that was identified was co-occurring disorders, as well as historically underrepresented participants. And so the portion of the bill basically stated that they were going to allocate funding for a clinical trial that would allow us to explore those two areas. And so me, in conjunction with a lot of other people, Dr. Darren Smith, Dr. John Rawl, we have a large cadre of people are in the early stages right now of developing a clinical trial that looks specifically at psilocybin plus psychotherapy for folks who are struggling with both PTSD and alcohol use disorder, specifically looking at veterans and first responders at this stage. It'll be essentially a safety and efficacy trial to really just demonstrate that we can administer psilocybin to this patient population that is historically quite high risk and has been excluded from a lot of the current studies. So just wanted to let you all know that that work is underway, and yeah, I'm happy to answer any questions about that and see how I can keep everyone up to date about that process.
Nathan, thanks. Can you just walk through again time frame for you?
Yeah, so the bill states that we need to start administering psilocybin by the 1st of January of 2025. So the current plan is basically it'll probably take us the next year to jump through all the regulatory hoops. And then our hope is to start enrollment in about a year. We're looking at a number between probably 30 to 50 participants. And then once we start to enroll people at the first of the year of 2025, it'll probably take about a year to complete all the data collection. The intervention is 12 weeks. But then we're going to do longer term follow-up and look at different biologic markers and safety markers over a longer term period. So so that's where we're at. So it'll probably be a 2 to 3 year time frame.
Got it. Thanks, Nathan. Any other thoughts, comments for Nathan? And anything else for Val? Val, thanks so much for giving that overview. I think it was really helpful just to make sure we're all on the same page there. Any other?
Well, yeah, I have a question for Nathan. Nathan, are you going to use psilocybin, the pure molecule, or psilocybin, the mushrooms? And if so, where are you going to obtain the mushrooms?
That is a great question, Paul. I'm glad you asked. So we're in the middle right now trying to figure out that exact question. My hope, because this trial is being funded by the state to essentially answer questions of safety, my hope is that we could find a way to use the entire mushroom, given that the eventual goal is to potentially have a program that we administer the whole mushroom. So my aspiration is that we can find a way to get the entire mushroom. But as you are all too familiar with, Paul, there is a tremendous amount of bureaucracy and challenges associated with that. So one of the goals that I have in the next few weeks is to try to sort through where those barriers exist and if there's anything that can be done to push through those barriers and try to figure out if there's a way we can source the whole mushroom. I don't know if that's going to be possible, but I'm very hopeful and going to work very hard to see if we can make that possible.
As a follow-up, we're licensed and approved by the DEA for 100 grams of pure psilocybin. So at 1%, 2%, you can do the math on that. So we can still provide a lot. We have the capability of doing so. In many states, including California and Arizona, the Department of Health is not the gatekeeper for being able to cultivate psilocybin mushrooms. Washington State is uniquely conservative, and we are fully capable of growing 4 terrariums full of mushrooms, enough for a clinical trial. That's all it takes, folks. The space of your desktop computer right now on your table is all the space we need to grow psilocybin mushroom for a clinical trial for Nathan. We would love to overcome these obstacles, and we're hoping to work cooperatively with the Department of Health before we make a decision to take our resources elsewhere.
Thank you, Paul.
Thank you.
I mean, that would be the ideal. If we could figure out a way to source it locally, that would be fantastic. But we can talk offline more about that.
Great, thanks, guys. Any other questions before we transition over to regulatory structures? Okay. Duncan, you ready to go?
Yeah, I am. Hi, everyone. I've met most to all of you, but my name is Duncan Stewart. I'm a research assistant with the Center for Evidence-Based Policy. And apologies, I'm in a bit of a storm system, so if my Wi-Fi cuts out and you miss anything, just tell me. But we can go to the next slide. So as we talked about earlier, the work group was tasked with a variety of directives, and the directive that I'm going to be focusing on today and into the future will be to review and discuss regulatory structures for clinical use of psilocybin in Washington and other jurisdictions nationally and globally. This should include discussing how various regulatory structures do or do not address concerns around public health and safety the task force has identified. So as we were saying in the beginning, the goal of these meetings in general is just to kind of have open conversations. I'm going to be going over today both the international regulatory structures that exist kind of at a high level, and then also spend a very small bit of time talking about ketamine therapy and the use of ayahuasca. Just to give a general overview of the regulatories that do exist domestically and internationally, as is directed to us by the bill language. And I hope that you all give some feedback about what you think is relevant to our work in Washington, and also just in general to any thoughts or questions you have on these international structures. And then moving forward, what I'd like to do is, there we go. Moving forward, what I'd like to do is cover the existing regulatory models in the United States, so Oregon, and the emerging regulatory structures in Washington and Colorado, and then hopefully discuss kind of some hypotheticals and the safety and equity features that go along with them. So that's kind of the background, and I'll go into it now. So I'll take the next slide. So just as a brief overview, psilocybin is considered an illegal substance under the 1971 United Nations Convention on Psychotropic Substances. Most countries do classify psilocybin and other psychedelics as illegal, but the countries that are exempt from that, that do have some form of legality, vary in how they're used and regulated and enforced. And so nations kind of follow these three general categories, are the ones that I've kind of gone over have in my research. We have full legality, so the drug has never been and isn't currently illegal in the country. We have non-enforced illegality. So though the drug may be technically illegal in certain circumstances, there is either like a very, or there's just no prosecution in general. So there's no action taken by law enforcement to restrict use or distribution. There's no risk to the individual or to the group handling these substances. And then lastly is medical legality. So psychedelics are legal for specific individuals with medical exemptions under certain qualifications within the law to treat certain diagnoses. So those are the categories. I'll take the next slide. So to start, I'm going to talk about the Netherlands, which is kind of famous, at least in the West, for being a country with very liberal drug policies. An incident in 2007 involving the suicide of a French tourist while using psilocybin mushrooms led to political backlash and action by politicians in the Netherlands for stricter regulations of mushrooms. Psilocybin was banned in 2007, though the truffles, psilocybin truffles, remain legal kind of through a loophole in the law. They continue to be sold to this day in the Netherlands legally and have a market for them, though the mushrooms themselves cannot be sold. My amateur understanding of the issue is that truffles can provide nearly the same, if not the same, effect that psilocybin mushrooms can provide. And then throughout this time, both during the ban and not, research exemptions have been allowed by the government in the Netherlands. even though the mushrooms themselves are legal. In Brazil, there are no instances of law enforcement taking any action, even though the mushrooms themselves, the substance, are technically illegal in certain cases. The Brazil law enforcement has not taken any action against those possessing or distributing mushrooms, and therefore there is an informal market that exists in Brazil. Additionally, in 1992, traditional ayahuasca practitioners won legal battles against the Brazilian government, and since then have retained full legal access to practice using ayahuasca under the law legally. And then, just as in the Netherlands, there are a variety of research institutions that have legal right to use and do research with psychedelics. Specifically, there's a lot of research being done in Brazil on the effects of ayahuasca on mental health, etc. We can go to the next slide. Okay, so the next two, which are possibly the most relevant for what we're considering in the US, is Canada and Australia. Both of these countries are implementing a medical model, which means there are certain exemptions to certain laws that are allowing for the facilitation of psychedelics to people with certain diagnoses. So in Canada, psilocybin was made legal in select cases under the Controlled Drugs and Substances Act. And then more recently in 2022, Health Canada amended the Special Access Program, which expanded access and allows medical professionals to request psilocybin therapy for certain patients for certain conditions. So this primarily in Canada plays out as end-of-life care, but can also be prescribed in cases where other therapies fail. So for treatment-resistant depression, et cetera, to aid a patient. And then in Australia, this was even more recent. Australia has legalized and recognized as medicine both MDMA, specifically for the treatment of PTSD, and psilocybin, specifically for the treatment of treatment-resistant depression. This therapy program, psychedelic therapy, will be legal by July of 2023 for those who qualify with certain diagnoses, and they will be under strictly controlled medical settings. So the regulations surrounding how that therapy will be practiced is still developing, and I will continue to pay attention to that as they do develop their regulations. But for now, the information out there is that specifically authorized psychiatrists will be able to prescribe treatment to individuals with certain diagnoses, and then there will be medical professionals trained in some way, which is still being developed, to facilitate either MDMA or PTSD for those specific diagnoses. And then the last thing of note in Australia is that there was a rescheduling to Schedule 8 for therapeutic use. So those who are given permission and are authorized to be using these substances are no longer handling what is the equivalent of a Schedule 1 drug in the US, which is a Schedule 9 drug in Australia. So it remains a Schedule 9 drug for unauthorized use, but in order to provide protections for psychiatrists, medical professionals to use any of these drugs, it has been rescheduled to Schedule 8. We can go to the next. And then lastly, I wanted to mention Jamaica. So Jamaica has never made any psychedelics illegal, and has, as I'm sure many of you know, has kind of supported an informal psilocybin and drug market in general, and has been participating in drug tourism for many years. In 2021, legislatures in Jamaica revised drug regulations. So though primarily aimed at kind of allowing for cannabis regulation and distribution to kind of grow easier, it also allowed for psilocybin to be distributed, which led to the establishment of the first legal psilocybin smart shop, is what it's called, which is a fully legal and government authorized store in Jamaica, opened in January of 2023, that sells psilocybin mushrooms and has no role in their facilitation. So simply a place for retail of psilocybin mushrooms. And then some notable cases are ibogaine remains an unscheduled drug in Mexico, which has allowed for treatment centers to proliferate in the country with very little legal risk, even though its classification as just an unscheduled drug means there is some gray area in terms of legalization. Peru has legalized ayahuasca. And then the last bullet point I have is that multiple countries have decriminalized all drugs. So there's this kind of general trend across the world to change the way we perceive how drugs should be treated within the law and whether they should be criminalized or not. So we can go to the next slide. I wanted to pause for a second. I realized that all these kind of international cases may not be directly applicable to the US, but I feel like they do have some lessons that can be learned from them. And so I wanted to ask for any feedback in general. And then I'm also going to just provide a guiding question, which is addressing Australia and Canada. They're both moving to implement a medical model that requires a diagnosis for treatment. And this model hopes to make use of the existing medical apparatus to promote public health, regulation, safety, et cetera. And so I'm asking is whether the reality of the medical system in the US, even though Australia and Canada are similar countries, does this change the potential effectiveness of a medical model? Does the fact that Australia and Canada are moving forward with relative regulatory frameworks, does that change kind of our perception of whether a medical model is viable within the US? And I'm happy for any feedback in general on just international regulatory frameworks. And if nobody has anything to share, I'm happy to move on.
I saw Cody's comment in the chat there.
Oh.
I might also add there, I believe Mexico also allows for the religious use of psilocybin. I believe there are actually several countries that do allow, that do have religious protect as well. I mean, you can get into similar detail with this, but it really depends on how far you want to get.
Right. Yeah, that's interesting.
This is Paul Stamets here. I would add that the potential of psilocybin is the universality of use, especially with neurodegenerative consequences of aging. And meta studies are not necessarily causal and effect studies, but there's very strong increasing body of evidence that a one-time experience or multiple time experience with psilocybin statistically is associated with a reduction in crime, with violence. And so I see this as much bigger than just treating people who have diagnoses. It could be also a very good preventive and preventing people from having PTSD or having the trauma that they could otherwise deal with. And I think, on a global viewpoint, this could save the state of Washington billions of dollars by preventing people progressing into mental illness. So the picture should not be restricted just therapeutically to people who are medically diagnosed with a condition. I think functionally, this is a basic civil right that we should all have the rights to our own consciousness. And we should not have just one bucket, but have the religious exemption, the therapeutic medical application, and also allow people to be able to buy this and use it for their own personal spiritual purposes, however they wish to define those.
Thanks, Paul. I think that's a good point. Anybody else have anything to share? All right. Well, then I'm going to move on to my last two slides here. I'll take the next slide, Beth. Thank you. Okay, so lastly, I just want to do a really brief, just for kind of providing context on regulatory frameworks and what's going on in the US in terms of other psychedelics, is discuss ketamine and ayahuasca. So though I'm sure there are many people here that have far more knowledge on the use of ketamine. I wanted to go over the use of ketamine in the United States. So ketamine is a Schedule III substance that is approved by the FDA for use on individuals with treatment-resistant depression. So prescription version of ketamine called esketamine was approved in 2019. There are a variety of ways to take ketamine. That can be intravenous, it can be intramuscular. There's kind of a small body of dissolving tablets that are starting to be used. And the FDA guidelines state that it can only be used under the supervision of a healthcare provider and a certified doctor's office or a clinic. That being said, due to its nature as a Schedule III substance, there is significantly less regulation surrounding what is a booming industry of ketamine therapy and ketamine therapy clinics. The way in which ketamine is traditionally facilitated is very similar, or is the most similar to psilocybin than any other form of drug or therapy combination. There's a variety of kind of, as we've been talking about in this work group previously, a variety of different ways to facilitate psilocybin, and therefore a lot of different ways to facilitate ketamine. The degree of talk therapy associated with both the integration session afterwards and the extended integration, the degree of medical training, whether it's an MD or a PA, et cetera, the facilitator guidance, how much is your experience kind of a guided experience versus a largely kind of internal and personal experience. These are all kind of left up to the discretion of the ketamine clinic at the moment. There is no tangible form of regulation. That being said, there are a lot of similarities between ketamine therapy and psilocybin therapy. And so I think potentially a deeper dive into what strategies are used in ketamine therapy clinics and what is proven to be effective versus not could give some context to how we understand how psilocybin therapy should be facilitated in Washington State. And then lastly, it should be acknowledged that ketamine therapy, similar to our concerns around equity for psilocybin, is very expensive. A single session can range from $400 to $800 and can surely exceed $800 as well. And so there are a lot of equity concerns to be considered associated with ketamine and possibly some learning lessons from that. And I'll go to the next slide. Lastly, I wanted to talk very briefly about ayahuasca use in the US, just to provide some context. União de Vegetal is a religious organization that in 2006 won the right and maintained the right for certain religious organizations with legal exemptions to continue practicing and consuming a Schedule I controlled substance within their practice. UDV is a church. This specific church was the New Mexican branch of what is a Brazilian church that uses a sacramental tea containing ayahuasca. Both UDV and the Santo Daime are the only two religious organizations that have this exemption, this federal exemption to use this Schedule I substance. Santo Daime only has, though is also a Brazilian religion founded in the 1930s, it only has approval for use in specific states, but that includes Washington and Oregon. And in recent years, as we've seen kind of this like rise in popularity, this so-called psychedelic revolution, we've seen an increasing prevalence in ayahuasca churches, and not just ayahuasca churches under the UDV and Santo Daime, but other ones that claim kind of these religious freedom exemptions without having specific exemptions from the federal government. And this, as a result, has seen an increase in kind of scrutiny and seizures of ayahuasca as the proliferation of these churches increases. And so that's my brief overview of ayahuasca. We can go to the next slide. Does anybody have, these are just broad questions. Does anybody have any feedback or thoughts on the use of ayahuasca or ketamine within the US?
Duncan, this is Sharice. This is great. I guess my only other question, I had to step away for a minute. Maybe you mentioned this. I'm told, and maybe Nathan or other folks on the call can weigh in. It's my understanding that MDMA will be available as a therapeutic modality sometime in this year or the next. And it's not exactly the same, but I wonder if looking at some of the considerations around that, the use of that might also be informative as we move through this. I'd be curious to hear what Nathan or others on the call think.
Yeah, I've heard the same chatter that MDMA will be rescheduled in the near future, and there's certainly some interesting regulatory challenges that are being faced with how does the FDA regulate psychotherapy component and so forth. So I think there's some interesting parallels and certainly some lessons that could be gleaned from that.
Yeah, and as that regulatory framework develops, I'd be happy to look into that. Well, thank you everyone for listening to that. That's just kind of the regulatory overview, and we'll go deeper and it'll hopefully get more relevant as we get closer to looking at Oregon and Colorado and regulatory structure.
Duncan, just one other follow-up on my end, and this is really to the the work group and almost or to the task force, and to Lisa's point earlier, other kind of key questions or feedback. So as Duncan is kind of putting together this framework, we are kind of looking for your guidance into, other things that we should be looking at. Anything else that you would want to see as we start to kind of almost build out a framework for regulatory options. So anything that you guys have or want to, shoot to us or give us some feedback, that will really kind of be our work over the next, 3 to 4 months to bring something that you guys would like to see in terms of this overarching regulatory framework that you would then kind of put in this legislative report. So the things that you know about, we would welcome that. So I think Duncan's been doing a phenomenal job of just even trying to gather all this. But if you have anything that you know of, please send our way.
Thanks, Mike. I think, I wanted to respond. I think, Paul, your comments earlier, and I see, concurrence in the chat, that sort of thinking about the availability in 3 levels. As we mentioned earlier, we have sort of our task as an agency to focus on the clinical, and I'll put that in quotes given our conversation. But I think there's also the wellness and I can't articulate the 3 levels as you did, but I think, I've been engaged in a number of conversations over the weekend around mental health and substance use disorders and behavioral health more broadly, not necessarily, related to psychedelics, but traditional treatment and all the stigma and discrimination that remains around those. And I think that, one of the things that it might be worth some comments today or at a future meeting is, the public is not always informed, certainly not as well informed as this group is. And, the press around the most recent shootings at the Gorge a couple weekends ago, whether or not that person who did kill those concert goers was in fact using mushrooms or not, I don't know, but that's what was in the media. And so I think, an example of somebody behaving badly out of the tens of thousands or more of people that are using things is always news, but it's not necessarily useful. And so I just put that out there. If there's any need to comment, I don't particularly feel any, but I do think that, there remains, I think, a lot of misinformation and misunderstanding, and just I think that's a part of all these discussions, maybe not this group's work, but wanted to just put that out there if anyone had any comments or thoughts around that.
I have a very important comment. I have a lot of experience with Amanita muscaria and Amanita pantherina, which does induce violence. And so when people say they took mushrooms, well, I would know immediately, do you have samples? It's a Psilocybin cubensis. It is an Amanita pantherina. I've eaten pantherina muscaria many times. It induces repetitive violent behavior. So this is very important that we be careful. Just don't, when they say mushrooms, what does that mean?
Right.
Let's be specific. Let's be specific and scientifically accurate, and let's demand a level of documentation that's necessary to inform us to make good decisions. But this is a perfect example of the ambiguity that the media will then project a narrative that then could influence our policy. I mean, think about that. We have to be very, very careful and make sure that we're professionally and academically correct and kept to a high standard, because I don't want these type of stories to hijack something that could have benefit massively for society. Thank you.
Thanks for those points, Paul. Very important.
And I see a little activity in the chat too. Some questions about Oregon, Colorado, and Duncan, I think you've got that lined up for the next meeting. Is that right?
Yeah, I'll go over that next meeting, or what exists on it. Yeah.
Perfect. Yeah, I think that's the whole. We'll take a deeper dive there, because there is a lot to start to flesh out there in terms of, you guys weighing in on, regulatory structure at the state level and understanding what's happening in both states and what you like, what you don't like, and then kind of passing those recommendations on in the report.
Paul, would you mind putting those 3 tiers that you referenced verbally in the chat if you are at a computer, just so as we move forward in thinking through these, we can kind of keep those
Yes.
threads aligned. Thank you.
Good, I'll do that right now. Thank you.
Beth, can you go to the next slide? So can we, Beth, you can take that off screen right now, I think, because I wanted just to take a second and make sure we had a chance just to walk everybody through what we're thinking about in terms of a proposed work plan. In the legislation, we actually were tasked to kick off this task force by the end of June. So we quickly kind of mobilized all of this, and now we're meeting on the 26th. So we're on target, but we've started to mobilize this work very, very quickly. And again, thanks to Val and Duncan for pulling all together, as well as Haley. But as we move forward, what we're tentatively looking at is another work group meeting towards the end of August, and make sure we have time to kind of get some work done and kind of hold tight on summer schedules. And then convene again at the end of September. So we'll have two more meetings to get kind of further in depth on Val's kind of review of the research, and then more into the regulatory, structure review. So again, two more meetings with some additional feedback and refinement that will start to then build this report that then gets handed over to, or these recommendations from you guys gets handed over to the HCA team to finalize a report, and then get turned over to the legislature on December 1. So as you think about kind of your involvement and scope, that's really what we're looking at. We'll probably have some materials in advance of these meetings to make sure that you guys are reviewing everything in advance, and then come prepared to have those deeper discussions. I imagine these would be most likely a minimum of 2-hour meetings that we would have at the end of August and into September, maybe a little bit longer. We'll have to kind of see how much information we have, but go from there. And Val, if I could just maybe ask you, when you think about kind of the next round of information to be presented, how kind of thinking about what you would be coming back to the work group with in the end of August. Can you give maybe a high level overview of what that might look like?
Sure. I think what that will be is sort of what the Oregon Review had gotten to in terms of a finding, and then what our update says about that. Is there something new here, or is there nothing, or is it all the same, or is there something really different that we're seeing? So I would expect it in those kinds of categories by the key question. So risks and benefits. I don't think we're still going to see much about formalized or validated assessment instruments, but if there's anything there, we'll let you know. And then you can anticipate whatever we're able to find on subgroups. So by clinical condition, by personal characteristics, et cetera.
Awesome. Thanks, Val. So everybody kind of clear on that? Any other kind of feedback, guidance, recommendations as you think about Val and her team moving forward with that? That all sounds good.
No, Mike, nothing around Val's comments. I wonder maybe to some of the comments earlier, and maybe not related to the specific requirements that the healthcare authority is bound to through the law. We may, depending on resources and timing, try to have another meeting somewhere in there just to kind of focus a little bit more on the personal use for prevention, supporting personal mental health. I mean, if I'm thinking about, it is not, I think I'm comfortable saying that discussions around religious use is not purview of this group. I think that doesn't necessarily make sense to have that discussion here. I do think the regulatory requirements that will be required in a clinical setting, those we kind of have to deal with those already, right? We kind of have an understanding of what those might look like, short of the finding mushrooms and using them, as Nathan mentioned. I think that will be something, but sort of some of the considerations for personal use for prevention or supporting personal mental health, those are some of the broader societal stuff that this group focused on with the wellness model. And so maybe we'll want to be able to have a conversation sort of, thinking about pieces of that, because they will be different, I think, between the clinical and again, want to, take advantage of the expertise of this group to be able to provide information maybe that we're not being asked for, but that might be useful as whatever Senator Solomon and whomever else in the legislature continues to move this work forward. So give that some thought, but we may try and maybe do that.
Thanks, Teresa. And Teresa, as you just mentioned that, again, not to put anybody on the spot, but Senator Solomon, as you kind of hear this discussion today and kind of what's been outlined and what we're proposing moving forward, one, just kind of check in on your end. Feel like this is a good fit. There's legislative, and we're kind of meeting legislative intent. Anything that you would offer for recommendations moving forward?
Thank you for asking. I think I should maybe reflect on that. I just wasn't prepared for the question.
All good, all good.
But yeah, happy to circle back.
Okay, that sounds great. Thanks.
Thank you.
All right. We certainly want to, we wanted to leave ample time just to sort of get thoughts and perceptions from the committee members. I've certainly talked more than I needed to, and we've heard from others, but really wanted to just leave some time for folks to share any thoughts, suggestions with the group, comment on what we've talked about today, sort of what we've discussed as plans going forward, recognizing again that what we are able to do, we are somewhat limited, but also recognize the opportunity we have here to elevate your knowledge and experience to a broader audience. So I want to make sure that we do our best to honor that. All the lectures, 4,000 per person. Geez. AG, do you want to share that verbally or talk more about that? And no need to if not, but
I'd prefer not to
that's fine.
Say too much. I am better writing stuff out for
Perfect.
organization
Not a problem.
of it. Thank
Okay.
you. Bye.
Perfect. John.
Yeah, thank you, Teresa. There's an emerging set of research and a nascent literature on inappropriate use of these compounds. And we're all talking about the appropriate use, and that's clinically relevant too.
Mm-hmm.
And yeah, I'm not in any way trying to castigate or stigmatize the substance or people who use it by bringing that up, but sometimes they're used inappropriately. Or perhaps somebody has a condition we don't fully understand that interacts in a detrimental fashion with them. I hear from a lot of ED physicians, especially on the Eastern Seaboard, about complex patients coming in with methamphetamine, alcohol, psilocybin, and they don't really know what to do for those people. Now, does psilocybin contribute much to that presentation? Probably not. I'll say that, but still, I just think there's this other clinical piece we might want to toss in there, just in the vein of, let's hope we get to a good place with this, where we can use this product effectively. And on the weird chances something goes awry, we want to be able to address that quickly too, so there's not a negative backlash. And then that would all tie into like me sitting here at a medical school. How do we train students about that, etc. So sorry, I'm kind of long-winded there, but you probably get what I'm trying to say, I hope.
I think it's it's rare now that the drug-related toxicities are standalone. We know what to do with those. But as our most overdose-related deaths, they are not single substances. And so teasing out what contributes what to it is always challenging. But I do think point well taken. And Valerie, I did hear you kind of talking about trying to identify sort of, groups that may be more prone to challenges in part of your review, if I recall, or maybe I was dreaming that.
Yeah, no, If there is anything in the literature that we review that seems to indicate more adverse events or harms or other types of risks based on personal characteristics, medical or psychiatric comorbidities, other demographic or clinical features, we would report that to you. I'm actually a little bit dubious that we're going to find much there just because the clinical trial populations are so selected. But we'll report whatever we can find.
Yeah, I completely agree, Calvary. There won't be much there. And I just want to be clear, folks, I'm not saying this is going to happen maybe ever, but we should be ready for it if it does. Sorry, Paul, I didn't mean to speak over
Yeah,
you.
no, I'm about to go out of range. I've been ferry hopping. I'm going to go into a dead zone in about 3 minutes here. But I just attended the MAPS conference, and I see AG was there. It was phenomenal, 12,000 people. You know, NIH, HHS, you know, the DEA, all Johns Hopkins, Roland Griffiths. I mean, it was the who's who of the psychedelic scientists and stakeholders in this movement. But I had an interesting conversation with HHS, and one physician there who is way up the command chain said, you know, I have one question to ask you about psilocybin. And he was working with the words, and I said, it's valuopathy, right? And he goes, yes. So we've done a deep dive into valuopathy because of psilocybin, docs or the 5-HT2A, actually psilocin, and the 2B receptors. But this is where I admire the precautionary principle, and this is also related to adverse events and the ER and looking at confounders and whatnot. But I'd just like everyone to take a step back and think about these few questions and facts. Serotonin docks with 5-HT2B. That's the receptor that fenfluramine was pulled off the market because of valvulopathy concerns. Serotonin is a tryptamine. Is there any tryptamines ever reported in medical history that causes valvulopathy? Fenfluramine is not a tryptamine. Well, that's one good question to ask. The answer is no, as far as my research. There are no tryptamines ever indicated in causing valvulopathy. Serotonin binds with 5-HT2B at just about the same level that psilocin does. So that's interesting. Psilocin has a half-life of 1.8 hours. I think fenfluramine is 22 hours. And then the doses that are being used, especially with microdoses, is way below that of the fenfluramine and other compounds, even though it does have a high binding affinity. Then I asked several ER doctors, have you ever had a case of valvulopathy coming to the ER with a psilocybin mushroom user? The answer has been no. So the precautionary principle is good to pay attention to, but let's be very circumspect. And this sort of knee-jerk reaction that psilocybin causes valvulopathy, when this thought has not been acid tested, nor is there a string of evidence suggested that it would. Some drugs, a few, that bind with 5-HT2B do not cause valvulopathy. And it all depends on what happens when it crosses the cell wall membrane and downstream effects. So I know there's some physicians here on the call. Please look into this, be a little bit more circumspect. If you've identified a tryptamine that causes valvulopathy, please let me know, because I've not been able to find one. And so I think this is a concern that we should pay attention to, but probabilistically, I don't think it's going to become something that's going to be a big concern. So I just want to introduce that. And I'd love to be put into an email chain or other chain with other scientists who've done a deep dive on this. I have 5 PhDs on staff, and we have done quite a bit of research on this very subject, and happy to share information to any physicians here who would like to get more data from us. So thank you very much.
Thanks, Paul. I will say that's not a concern I've had as a physician, but certainly it was one with phentermine. You know, one thing we could do, it may not be in the literature, but we could ask if there's interest in this group to see if the medical director, who's a ED physician toxicologist from the Washington Poison Center, would be willing to come and just spend a couple minutes talking about some of the calls they get. I know that as there is more use, there may be more people or not visiting EDs. I'd be happy to reach out to him and see if that would be, something the group would be interested in. And I see AG's posts. I think, one of the things that I'm mentioning that the Heroic Hearts Project has sent over 1,000 vets who've had multiple deployments out since 2017 of the country, and the waiting list is enormous. So clearly there is a benefit being achieved and desired of that. And I think that, as we have conversations about moving legislation and stuff forward, I think that one of the most powerful things when people ask how to move stuff forward is really having the voices of people who are willing to share their experience and their thoughts, speak to the groups who make the policies and the decisions, because people with lived and living experience are far more compelling than a bureaucrat like myself, who people get tired of hearing from. So I do think elevating the voices of people who have the experience and are able to share that it's hard to ignore. And I think that's partly why the section that Nathan is working on, the pilot project, was not vetoed in the bill. It's because it focuses on first responders and military persons with PTSD and trauma. And I think I do think that continuing to highlight the importance and the work in those groups is really, really useful. I see Lisa's comment about equity boards as part of the natural medicine wellness service legislation in Colorado and Oregon. I mean, certainly I think we have wanted to, and Senator Solomon wanted to, with his social opportunity program, elevate the intent. Certainly his intent has been, and I, from just what he said today, remains that this really, what we are trying to create, whether it's in the clinical setting or the wellness setting, is something that should be available to everyone. You shouldn't have to pay $400, $1,000, however much money to access wellness and well-being. And so equity is a huge part of that. And how do we, have that conversation be part of whatever we put forward? And so I think that, we're definitely interested in continuing to have that be a huge part of whatever we put forward. And as Valerie said earlier, the literature to date is pretty narrow. So we have a lot of opportunity. Yeah.
Thank you, Dr. Fontinos. Can I add to that?
Please.
So, obviously, I introduced the wellness model, and I think that will move things forward. There would remain a significant cost issue, which is troubling. So it's not the end of the efforts, right? There is also talk about the clinical model using Medicare to cover some of this. I think there's lots of challenges there in a variety of ways, but it'll be interesting to see if and how we combine a wellness model or a clinical model, or what we can do to navigate those two questions. I'm not sold on a purely clinical model as being the final and only and complete solution. So I hope, and I think we are going to continue to be open-minded. And it's not clear. So from this legislative session, it's clear to me that there's huge bipartisan support for something, but we didn't arrive at what that something is. I think we should be very encouraged by the bipartisan vote, because the hurdles then become questions of technicality. How do we, as opposed to whether we move forward. So as we do that, I think we're going to continue to have these discussions. Can we integrate a clinical and a wellness model? I'd love to do that if it works. Thank you.
Thanks, Senator. Teresa, I just wanted to, I saw that comment from Lisa there just on the equity survey. And Lisa, I think we're having some internal discussions. And I think as many of you remember, we kind of did this first round of the equity survey. I think we all kind of felt there's room for improvement in terms of not only the way that was crafted, but then also just the outreach and the number of responses. So we are kind of looking back and doing some revisions as I think, Duncan mentioned. So whether we call it a subcommittee or some variation, but I think we are looking at how do we mobilize a smaller group to kind of get together and do those revisions. So I think you're spot on. And I think we're going to kind of, I know the center, we're going to kind of follow HCA's lead, but we're happy to help. But I think that'll be part of, even though this isn't necessarily part of this task, we're looking at this as a continuation of that first round, because we think it really does tie directly to this. So I think further input feedback, we would welcome that. And Teresa, I don't know if you have any other thoughts on that about moving forward, but I think that's kind of the plan, that we'd like to mobilize a smaller group for that.
Agreed. There's also a comment from AAG about maybe inviting leaders of one of these veteran groups to be guests. I think that might be certainly a good idea when we and that certainly for veterans that could be both in a clinical setting or a wellness setting separate from clinical. So I think that certainly that could make sense. And see Cody's comments about payment for Medicaid, Medicare.
Yep.
And Englishes, yeah.
And Seth, any comments on that?
Yeah, thanks, Mike. Yeah, I'm totally open to bringing in some of these leaders from some of these other institutions and organizations. That's just going to educate all of you way better. I mean, AG mentions it'd be great to have a talk about experience, but there's some credibility that's coming from these individuals that are running these organizations that are being heard nationally and globally. So, and they certainly contributed to the MAPS conference in Colorado recently too. So. I absolutely would open the door to have them as a guest speaker if we were so lucky that they join us.
I think it might also be useful, Caitlin, I'm going to put you on the spot for a minute. You mentioned there were some lessons to be learned from the process with cannabis. We did have someone from the Liquor and Cannabis Board join us last session, but they were not able to stay through the course of our getting together. And so it's really kind of outside the purview of what our sort of legislated task is with this clinical review and models. But again, if we're going to try and raise concerns and sort of provide as much information as the state moves forward in whatever model it chooses, it would be good to kind of hear the perspectives that you mentioned, if you'd be willing to do that at a future meeting.
I also wonder about so going back to Dr. Rawls' point about looking at adverse events, if the purview of this task force is really to examine, the clinical evidence as it pertains to clinical applications, it seems like it's important that we be able to articulate and discuss the potential negative outcomes that will emerge, even if they're incredibly small, to kind of, as John said, to preempt any kind of pushback. I think we have a different standard in this, given the history and the context. And I also think we need to separate out kind of psychedelic advocacy to like the purview of this task force. I think all of us, by virtue of being on this task force, have similar opinions about the potential therapeutic value. But I think with that in mind, it needs to be understood that we're going to have a pretty high bar in terms of articulating the risks and benefits. And I think even if there's only a few case reports of bad things happening, it is up to us to really own that and learn from that and be able to comment on that thoughtfully.
Well said. Your dog agrees.
Yes, yes, she does.
Ooh, pretty girl. Other thoughts, comments from the group? Lacey, I don't know if you're still driving or want to share any thoughts from the Department of Health. If you are driving, just remain silent and we'll hope to check in next time when it's safer for you to do so. All right, no talking and driving. That's good safety.
I'm okay. Is this working now?
Yeah.
Okay. I'm not driving. I pulled over and parked, but my car Zoom is still in drive mode, so I can't see you all now. No, this was very helpful, and I think we are interested in hearing more and discussing more about potential regulatory frameworks in the continuum of ways we've discussed today, from a prevention wellness model through a medical model, and appreciate the insights and the expanded membership and look forward to the discussions.
Thank you. Mike, let me turn it over to you.
Thanks, Teresa. Guys, I just want to thank everybody. I think this was exactly what we really wanted to go through today, kind of this first kickoff, get everybody on the same page, kind of revisit a bit of the work over the last year plus, and then just talk about the work moving forward. So I think we started to lay out that path. I think you gave us some good feedback today. We will be looking at then kind of scheduling, and I'm sure you'll see a doodle poll from us in the upcoming weeks to see what we can get scheduled on the books for the end of August, and then we'll continue kind of our work on the research and then on the regulatory structures. So again, I think this was a great first kickoff. I think that's it on our end. Anybody else from center team, anything else you guys wanted to add before we look at wrapping? Great. Teresa, I think we're good on our end. Anything else you want to add?
No, thank you everybody for your time and attention and input. It's really appreciated, and we'll keep moving this work forward, and both in terms of what we were asked and required to do, but also what we want to elevate and raise for people who are going to be considering how to move this forward, so they have as much information as they can. So thanks all again for your participation. And
Awesome.
with that, yeah, everybody have a good rest of the afternoon and week.
Awesome. Thanks, everybody.